Welcome, everyone, to today's episode of Neurology Video Journal Club. My name is Dr. Shannon Chiu. I'm a movement disorders specialist, and I am currently an assistant professor of neurology at the University of Florida in Gainesville, Florida. And I'm joined by my co-discussant today, Dr. David Vaillancourt.
Hi, my name is David Vaillancourt. I'm a neuroscientist and with an expertise in neuroimaging. I've been working in the area of movement disorders for several decades now, particularly focused on Parkinson's disease and other motor disorders. It's a joy to be here, and I'm looking forward to the discussion.
Great. So today we'll be discussing an article recently published in Journal Neurology titled Brain Metabolism Related to Mild Cognitive Impairment and Phenoconversion in Patients with Isolated REM Sleep Behavior Disorder by Chiu et al. I think this is a really timely and interesting article, and by way of review for the audience, isolated RBD is increasingly recognized as a prodromal feature of alpha-synucleinopathies, and this includes Parkinson's disease, dementia of Lewy body, and multiple system atrophy. Recent studies have shown that average phenoconversion rate to one of these diseases is over 30% if you follow these RBD patients for 4 to 5 years. And importantly, the phenoconversion risk increases with time, where the estimated risk is over 90% if you follow them for 15 plus years. We're also learning that there's a high prevalence of mild cognitive impairment amongst patients with isolated RBD. Longitudinal studies indicated that early co-occurring RBD and MCI can actually be potential predictors of patients developing DLB or PD with dementia. So this is why understanding the pathophysiology of cognitive impairment in patients with RBD is so important, especially to help predict future phenoconversion to one of these neurodegenerative diseases. Now, prior studies have looked at brain changes in patients with RBD and MCI, but most have been either structural MRI or SPECT studies. So few have looked at brain metabolic changes associated with MCI and RBD, as Chiu and colleagues have done here. In the study, they also included resting state fMRI in addition to FDG PET. So go ahead and share the screen to start our slide. So the objectives of the study was to identify brain metabolic and functional connectivity changes related to MCI in patients with RBD, and also to identify predictors of phenoconversion. Now, this was a prospective cohort study of patients with RBD with or without MCI compared to healthy controls using baseline FDG PET and resting state fMRI. And all participants had baseline neuropsych testing, and then they were followed for an average of 4 plus or minus 2.6 years to monitor for phenoconversion to one of these alpha-synucleinopathies. Now, the authors hypothesized that patients with RBD and MCI would have relatively reduced brain metabolic and functional connectivity changes, primarily involving the posterior cortical regions based on what we know from prior studies done in Parkinson's and DLB. And they also hypothesized that the regional hypometabolism in these posterior regions could potentially predict phenoconversion. So let's go ahead and start looking at the actual patients that they studied. So in total, they had 40 RBD patients from the Seoul National University, and then they had 24 sex and age matched healthy controls. Now with the RBD patients, these all had polysomnography confirmed RBD by testing. And then none of these patients at baseline had PD, MSA, or DLB diagnosis, but then they were followed every 3 to 4 months during the study to monitor for phenoconversion. And then all of these patients had baseline neuropsych testing, so not just kind of screening MMSE, but also more comprehensive neuropsych battery testing. And then based on their performance, so the RBD group was then subdivided into those with MCI or normal cognition. And as you can see here, it's pretty even split between the two groups. And then table 1 here shows the baseline characteristics. And I would say the 3 groups were pretty well matched in terms of age, sex, education, and then RBD duration for the 2 RBD groups. So none of those were significantly different when they compared them. Now, not surprisingly, in terms of cognitive profile, the RBD MCI group had lower MMSE And then also based on what we know in RBD patients with MCI in terms of their cognitive profile, their group had significantly lower performance in certain domains, and that included attention, working memory, executive function, and also memory domain. And then the other thing that kind of struck out at me with their baseline characteristics was that the RBD MCI group had what appeared to be just a little bit more motor symptoms, kind of Parkinsonism, based on their performances on the MDS-UPDRS parts 2 and 3. So in part 2, that's the motor aspect of ADL, and then part 3 is the actual motor score. So the RBD MCI group did score a little bit higher, and that was significantly different. Now, David, did you see anything else that struck out at you based on the baseline characteristics of their cohorts?
Yeah, I really like how you explained it as well. And so a couple of things that hit me were, one is, the average age of PD tends to be lower 60s. And so when you look at this cohort, most of these individuals are closer up to about 70 years of age. So I think the cohort overall is older. And so I think that should be, certainly taken into context. I know we have an ongoing study in RBD right now, which tends to have patients who are a little bit younger than this. So I just think that is certainly a factor that might compare uniquely in this study compared to some of the other ongoing studies. A couple of other things that struck me. One, I completely agree with you on the idea that the motor symptoms clearly are there. They are subtle in these patients, but they clearly are there. I think it would have been kind of cool to have a UPDRS-3 or UPDRS-2 in the healthy control group as well, to kind of see, when you think of age matching, is this normal? Is it not normal for that age group? I think that would have been nice to have seen. But not every study is going to have everything. So certainly not a big deal. And then the only other thing that I can see here, which I think is really important for this study and unique in this study, is they have such a long period of time before the phenoconversion. So, following patients for that long, 4 to 5 years, is a long time. And I think that's really what kind of sets this study apart, or makes this study unique.
Yeah, and I think those are really good points. And the other thing to go back to about the motor scores too is I wonder how many of these patients may have what we call kind of the early prodromal, either PD or Lewy body, even at this stage, though the authors did acknowledge that, they didn't look at chronicity of, motor versus cognitive symptoms, though. So it was a little bit challenging to subdivide, but I think those are really good points. So, and some of those features, as you brought out regarding the age and actually even maybe the lack of male predominance perhaps in the group, may factor into the results that we see. So in this first set of results, so the first part in figure 1 is where they were looking at brain metabolic changes based on their FDG PET results. And actually, the only significant results they saw were from the RBD MCI cohort. And so this was when they were comparing RBD MCI versus RBD normal cognition, and then the RBD MCI versus healthy controls. And what they consistently saw were that the RBD MCI group had relative hypometabolism involving the bilateral inferior parietal lobules, the occipital cortices and the lateral medial parts, the precuneus, and also the middle inferior temporal cortex. And then just in the analysis where they looked at the differences between the RBD cohorts, they found frontal predominance, some hypometabolism there too in the RBD MCI group. And then at the bottom here, they were looking at the correlation of the FDG PET results from the RBD MCI group versus the neuropsych testing, and they found 2 positive correlations. So one in the color word Stroop test, where it was correlated with hypometabolism in the left inferior temporal region, and then the verbal learning test was correlated with hypometabolism in the right angular gyrus. So now, based on what we know with prior FDG PET results and RBD-related metabolic pattern, are there results here what you would expect, or anything that struck out that you are surprised you didn't see, David?
Well, I mean, I think what you said about the occipital changes, the temporal changes, though, that is kind of what you might expect a little bit. If you think of the work of David Eidelberg, he's certainly shown changes in PD patients using the PDRP, which is the Parkinson's disease related pattern. And in that studies, and all those studies, they really show basal ganglia changes. They show cerebellar changes also. I don't see those here. It may, now these people also don't have Parkinson's disease, and that may be a factor. But nevertheless, I think I thought it was interesting. So, certainly the occipital cortex is really, I don't know, what jumps out to me is the most robust in this study. There's a little frontal activity changes, some temporal changes, but really the occipital cortex is where it really seems to be driving many of the results. And I do think that when you think of early cognitive changes, that certainly is consistent with some of the regions you might expect. But I also thought there were some regions that didn't show up at the same time. Another thing that struck me here is whether, RBD was a big deal here. So, initially, if you look at these data, it's not clear that having RBD is the major driving factor here. And it would be kind of neat to have an MCI, no RBD group as well, to kind of see how those changes would differ in the compared to the RBD with MCI group that they have here.
Right. And I think it's also interesting that, I guess, to speak to that point in terms of how much RBD in and of itself, versus the MCI component is playing a role, because they saw no significant difference when they compared the RBD normal cognition versus healthy control. So they didn't see kind of what we would expect, like the RBD related pattern when they did the normal cognition versus healthy control. So so moving on to the next part. So this was looking at the functional connectivity changes. So this was incorporating the resting state fMRI data. So they used the 17 seeds regions that had significant hypometabolism from the RBD MCI cohort. And what they found, so again, they actually only saw significant differences when comparing the RBD MCI group versus healthy control. And they found that the RBD MCI group had decreased functional connectivity involving the left angular gyrus and along with the posterior region. So again, the occipital cortices and the lingual gyrus. Is this what you would expect? Or I guess what we talked about with figure 1, is this surprising or in line with what you would expect?
I mean, I think it's in line. I think one thing that it shows is that the resting state fMRI findings are not as robust as the FDG PET findings. And I think that might be what you might expect from the literature, but it, certainly novel to see it here in this cohort. So I thought that was quite striking here. At the same time, you do see some of the effects in the resting state data, which are compatible with the FDG PET. It just doesn't quite seem as robust as the FDG PET findings.
Mm-hmm. And actually one thing, the sample size of the participants who underwent resting state was actually a little bit smaller. So it was only a subset of patients who originally had the FDG PET who went on to have the functional connectivity analysis. So maybe the smaller sample size could have contributed to maybe some of the less robust results. So moving on to their last part in terms of their results. So this was where they were looking at predictors of phenoconversion. So as you recall, these patients were followed for an average of 4 plus or minus 2.6 years. And so out of their 40 RBD patients, 12 phenoconverted, 5 were from the RBD normal cognition group, and 7 from RBD MCI group. And then the breakdown of their diagnoses are listed here. So in this table here, they actually break down the baseline clinical and demographic characteristics of non-phenoconverters versus phenoconverters. Now, the sample size of the phenoconverters, understandably, is a little bit small. So perhaps that is the reason why we don't see any significant differences between the groups. But I did think that was surprising. Age is perhaps they were a little bit older in the phenoconverters, and there is a little bit more of a male predominance in the phenoconverters, but again, not significantly different. And then the motor score, again, a little bit higher than the phenoconverters that we talked about earlier in terms of Parkinsonism, maybe affecting some of the RBD groups a bit more, but again, not significantly different. And interestingly, MCI was not different either. So in the Cox regression analysis that they show here, MCI in and of itself did not predict phenoconversion. But when they looked at the FDG PET results, so based on the regions that came out with significant hypometabolism in the RBD-MCI group, they did find 3 regions, all involving the posterior aspects, that did appear to predict phenoconversion. So now, based on what we saw on the prior slide with their FDG PET and resting state fMRI, are you surprised by what they saw here, David?
It did kind of surprise me. If I would have not seen this slide, and just seen the other data, I would have certainly thought that MCI would be a predictor. But it's clearly not by the way the analyses are done. So I think we just have to take that and then kind of ask the question, well, why not? And one of the things, that kind of I was thinking, Shannon, when we first talked about this article, that I didn't think about initially, but would be kind of neat to do is, if you think about an RBD patient, well, they might go get PD or they might go get DLB, for example. So if you're going to get PD, you're more than likely going to have some motor changes early on. If you're going to go on to get DLB, you might have some cognitive changes early on. So looking at one scale may not be a great predictor of phenoconversion, because some of your patients are going to get the motor symptoms and some of your patients are going to get the cognitive symptoms. So it might actually be better to say, well, if you have at baseline a certain if you're in a certain confidence interval or certain standard deviation away from the mean of your normal age group for motor symptoms or for cognitive symptoms, then maybe you use that as the predictor instead of the cognitive or motor separate, because the motor by itself or the cognitive by itself is probably not going to predict, because some patients don't go get cognitive symptoms and some patients don't go get motor symptoms early on. So really just having some sort of metric which combines the motor and the cognitive deficits, I think might actually be helpful here. But I don't think they did that, but I think that'd be kind of a cool analysis to try. That doesn't mean it would work, of course, but I think it'd be kind of cool to try.
Yeah, that would be really cool. So it's almost like a composite score. Is that what you mean?
Exactly. And it makes sense because if you think about the RBD, certainly in their study, some got DLB and some got PD, which basically means some are having motor issues and some are having cognitive issues. And so using a motor scale as a predictor doesn't make sense, and using a cognitive scale as a predictor doesn't make sense. So having some sort of composite scale might make more sense, or just looking at some sort of, like, if you're an outlier of your motor symptoms, then maybe that's the person that's going to go on to get PD first, or if you're an outlier in your cognitive symptoms, that's the person that's going to go on to get DLB first. Something like that.
Yeah, I really like that. I think that's a very cool idea. And I guess in terms of with their FDG PET results, the fact that they are still getting pretty robust signal in the posterior region, I guess that speaks to the point that in terms of an FDG PET signature, regardless of the cognitive or motor profile, it seems like this could be a helpful maybe biomarker to follow in terms of conversion for RBD patients.
Yeah, absolutely. I mean, FDG PET's fairly easy to implement clinically. The tracer is very robust. It's been around for a long time, and so I think the data here are very strong, and they certainly show a strong effect in the cut points. So I definitely think this is an approach that should be looked at in the future. And I'm sure that if you think of a pharmacological study wants to treat RBD early on, this is the type of cut point that might be helpful to determine those that might be predicted to be a converter versus not. So for example, you might want to treat those that are more likely to convert than those that aren't likely to convert, so that at the end of the day, you could test your drug to see if you've stopped the conversion rate or slowed down the conversion rate, for example.
Yeah, no, I think that's really good. And one of the things that the authors acknowledged here too is that this they only got data from one time point. So it would be nice to see kind of longitudinal follow-up to track progression, and that would be useful for in terms of with pharmaceutical drug trials to look for efficacy of the drug.
What do you think about the in a pharmaceutical study, most studies don't go for 4.5 years. So what do you think about that? Do you think that that's a time period that becomes an issue, or does that make sense? So most studies are 1 to 2 years. So this is a 4-year phenoconversion study. That seems like a long time.
I think that can be challenging, especially the patient cohort that we're dealing with. So I think when they're still in the early prodromal RBD phase, I think that's more feasible. But even thinking about, DLB patients, once they are no longer the prodromal MCI, but they actually have the dementia, they're struggling with hallucinations and other things. I think in terms of keeping them from, just falling out from the study, withdrawing, I think will be the hard part. So attrition, I feel like, would be the limiting factor the longer the study is. So I think if we're trying to maybe look more in the early disease modification, maybe just before patients are perhaps when we think about PD patients, for example, we try to capture them before they're on levodopa, for example, which indicates they're still in the really early phase, or even on Azlac or other medications. So I think if we're studying that cohort, maybe a longitudinal study could be more feasible. But yeah, I agree. It could be harder once they do have, definitive PD, DLB, or MSA diagnosis. And so I guess I'll just conclude and say thank you very much, everyone, for joining our episode today.